are going to go over the answers to the endocrinology cases that were attached to Lecture 17 and to the endocrinology module, and that you completed as an assignment. So let's start with case 1. We have a 14-year-old girl who's brought into the pediatric emergency room after a day of abdominal pain, nausea, and vomiting. She gives no history of exposures to people with gastrointestinal disease, denies diarrhea, denies hematuria and dysuria, but notes urinary frequency. She's a thin and tired-looking young girl. Here are her vital signs. So she's afebrile, she's tachycardic, she's a little tachypnic. Her blood pressure is low, so she's hypotensive. Her height is 5'3", her weight is 98, and I have actually calculated her BMI, and it's less than 18, so she has an abnormally low BMI. She has dry oral mucous membranes, and you smell a sort of fruity odor similar to the odor of acetone or fingernail polish remover. Her heart exam reveals tachycardia, her lung exam is normal, and her belly exam is normal. She has normal bowel sounds, it's soft and non-tender. One of the tests that would be routinely done on anybody with these symptoms in the emergency room is a urinalysis. And so her urinalysis reveals some very interesting and important findings. The specific gravity of 1.030 is actually the highest specific gravity measured on a urinalysis dipstick. She has some protein. She has no evidence of white blood cells or red blood cells on the dipstick, but she has very high ketones and a very high glucose. This is glucose, this is ketones. Blood work, of course, is ordered, and it reveals again some very important things. Her sodium is on the low side. Normal, you remember, being around 140. Her potassium is on the high end of normal. Her chloride is a little low. Her CO2, which is really measured carbon dioxide, and it's the value we use for bicarb, is 12. Creatinine is high. Her BUN is high, and these two together suggests that there's something going on in terms of dehydration and a probable pre-renal cause of these elevated kidney function tests. But here's where the money is. Her glucose is almost 500. So, why is her sodium low? Well, there could be a few reasons, one of which is that because of the very high blood sugars, we have changes in the function of a lot of transporters. But there's a more important reason, and that is that when glucose is very high, it takes up a lot of space. So if you're considering your serum osmolality is going to be quite high. And a big part of that is a large number of glucose molecules. The glucose molecules are displacing water and therefore causing sort of a false dilution of sodium. And so it is at least partly a falsely low value for sodium. In addition, that high osmolality in the extracellular fluid compartment, because remember that sugar The glucose is all in the extracellular compartment. It is not being appropriately driven into the cells. And so that also causes a real hyponatremia by diluting the extracellular compartment, drawing water out of the intracellular compartment and into the extracellular compartment. Why is the potassium high? Well, the big reason here is that the high level of hydrogen ions in this diabetic ketoacidosis as our presumed diagnosis. You remember that one of the ways the body attempts to buffer excess hydrogen ions is by exchanging them for sodium ions and putting them into the intracellular compartment where they're buffered. So a lot of potassium is actually coming out of cells and into the extracellular compartment. That raises measurable potassium, but we're also likely losing potassium in the high volume of urine. And if you looked at her total body potassium, even though her blood potassium is high, I would bet her total body potassium is low. Remember that you can't measure the potassium level of the intracellular compartment. What is the anion gap? So do you remember how to compute the anion gap? We add together the sodium cation and we subtract from it the anions, chloride and bicarb. So 132 minus 112 gives us an anion gap of 20, which is an elevated anion gap. In this situation, the anion gap is likely high because of unmeasured ketoacids because of her diabetes, and likely type 1 diabetes in a skinny 14-year-old with ketones in her urine. Her BUN and creatinine are elevated primarily because she is very dehydrated. She is urinating a lot because of the osmotic diuresis from the elevated glucose. Lots of glucose is filtering across at the glomerulus into the urine and holding on to water and leaving in the urine. So there's glucose in the urine, which has to be accompanied by water osmotically, and she is losing a lot of fluid and she's dehydrated. Her glucose is high for one simple reason. This child is not making insulin, and because she's not making insulin, she cannot use insulin, and therefore the insulin the glucose remains in the extracellular compartment and just keeps going up. I've already talked about her hydration status. She is profoundly dehydrated. But she's still urinating because of this diuretic effect of the high glucose that is filtering at the glomerulus and holding on to water. So that is a pretty classic presentation of diabetic ketoacidosis. It often occurs in children of elementary school and middle school age, high school age. It is an autoimmune disorder in which the beta islet cells of the pancreas are destroyed often after a relatively minor infection. And it has one treatment, which is insulin. This child will be given insulin. She'll be given fluids. She'll be given potassium, and over time we will return her fluid status to normal and her glucose level to near normal, and then ideally give her insulin for home use with lots of patient education for her and her family. Let's move on to the next case and its answers. We have a 34-year-old nurse who is brought to the emergency room after she's found incoherent at her desk on an inpatient unit. Her blood sugar's checked and it's 43, which is very low. Normal blood sugar, you remember, is around 100. When it gets lower than 60, people get symptomatic, and one of the symptoms is often confusion. She was given a bolus of D50, which is dextrose, which is glucose, given IV, and that's 50 grams of glucose, and she's almost immediately better. If you've ever worked on the truck or in the emergency room, you may have seen this. When people have very low blood sugar, just this simple bolus of IV glucose will turn them from combative, confused individuals to immediately coherent. She admits that a couple times in the past she's felt dizzy and confused at home, and that when she ate, she felt better. So think about what might have caused this. We mentioned a condition during the lecture called an insulinoma, which is an insulin producing adenoma of the pancreas that is not functioning under normal control. So people with insulinomas can get profoundly hypoglycemic because of excess insulin. But that's not the only thing that could have caused this, and this is actually based on a case that I saw when I was in PA school and on a rotation in the hospital. And the other thing that can cause this is exogenous insulin. So there are people who will give themselves insulin in order to fake illness. It's a one manifestation of Munchausen syndrome. So in the case that I'm remembering, the nurse was actually giving herself insulin and had several episodes before that was discovered. So if we check this patient's insulin level, is it likely to be high or low? And certainly it's likely to be high. If we were to do an imaging study, what would we be looking for? We'd be looking for an insulinoma. And there are different ways to do that. One potential way would be an MRI, but these sometimes are very small tumors. Another potential way would be to do an ultrasound endoscopically to image her pancreas from kind of a closer distance. And this final question relates to the possibility that this is a nurse who has access to insulin to determine whether the reason for her high insulin levels is that she has an insulinoma or that she is giving herself insulin. And there's an easy test to do that, and that is the C-peptide test. You remember that as insulin is produced, it is produced as a long chain which is folded and cleaved, and that the C-peptide, which is different and no longer attached to the insulin molecule, is discharged from the pancreas along with the insulin. So if she has high C-peptide levels that are consistent with her high insulin levels, she has an insulinoma. If she has low C-peptide levels and a high insulin level, it strongly suggests that the insulin that caused this episode of hypoglycemia was exogenous, was given, was injected. The third case is a 51-year-old who comes in complaining that he's tired, his energy is low, he can't do much without getting tired. When you look back at his chart, you see that he's lost about 12 pounds and he looks considerably older than you remember him. You do a good review of systems. He says that he has intermittent abdominal pain, he vomits now and again, and that he has noticed feeling weak and almost passing out when he stands up from a seated position. His vital signs are pretty normal. His pulse is on the high side and his blood pressure is on the low side. And your general impression is that he is a tall and thin, very tanned, tired looking man who looks older than his stated age. And on his oral exam, you notice that he has a lot of brown discoloration on his gums, and the exam is otherwise unremarkable. He has a BMP. Now, there are some things about this Chem 7 that may remind you of our previous patient. His sodium is low, his potassium is high, his chloride is pretty normal, his CO2 or bicarb is normal, 24 is kind of right on for normal. His creatinine is a little high, his blood urea nitrogen is a little high, and his glucose is on the low side. Here are our questions. Why is he seemingly tanned? Let's say this is in January and he hasn't traveled to the Caribbean. Well, he has an excess of a hormone called ACTH, or adrenocorticotropic hormone, which is chemically, molecularly similar to a hormone called melanocyte stimulating hormone, or MSH. And it has actions on melanocytes that have receptors for MSH to cause them to make more melanin. So people with this disorder often appear tanned. If we were to check a cortisol level, would it be high or low or normal? I would expect it to be very low. Cortisol levels vary throughout the day, and it's important to know the time of day it was collected and to compare it with the normal range for the diurnal cycle for the time of day it was collected. But it's going to be very low. If we were to check an adrenocorticotropic hormone level, an ACTH level, I've already said what it's going to be. It's going to be quite high in most cases. This is adrenal insufficiency, and if we are not making cortisol in the adrenal cortex, then the hypothalamus and pituitary are going to be trying to tell the adrenal gland to make more cortisol, so ACTH is going to be produced. Why is his blood sugar low? Again, Addison's disease is about a low cortisol level, and cortisol is extremely important in managing carbohydrate. If his cortisol level is low, he is not producing glucose by gluconeogenesis. He is not breaking down glycogen through glycogenolysis. And the low blood sugar, which should be triggering cortisol production to bring his blood sugar back up, can't. So he won't be making more cortisol. His electrolytes are disturbed for a couple of reasons. The adrenal cortex makes cortisol, but it also makes aldosterone. And when the adrenal cortex isn't working, often aldosterone levels are low as well as cortisol levels. And because of that, we do not reabsorb sodium appropriately, and we tend to hold on to more potassium. So more sodium is leaving in the urine and more potassium is being preserved. His renal function labs are high, again because he's dehydrated. Because of that additional sodium in the filtrate in the urine, that has to leave with water. So he is chronically losing sodium and water and getting dehydrated. If we were to give this gentleman a bolus dose of injected adrenocorticotropic hormone, his cortisol level wouldn't really budge because his adrenal gland has failed. And so giving him ACTH is not going to boost his cortisol level. But if you gave a normal person adrenocorticotropic hormone, ACTH, cortisol would go up. And this is actually a clinical test to check the function of the adrenal gland. It's called, I think, corticotropin stimulating test. Case 4 is quite different. In case 4, we have a 36-year-old woman who comes in complaining of fatigue and anxiety, of insomnia and restlessness, of palpitations and weight loss, and says she hasn't changed her eating habits. She thinks that she's getting panic attacks. Again, as always, you do a good history and physical exam, including an extensive review of systems, and you find that she's been heat intolerant, that she sweats more than usual, that she's having heavy periods and her menstrual cycles are more frequent, and that her bowel movements are more frequent and looser. Your general impression is that she's an anxious appearing young woman. She's sweaty. She has a tremor, and her eyes are unusually wide and staring. One thing to notice about these eyes is look at somebody in your life, and you rarely see sclera above the iris. To see sclera above the iris, the upper lids have to be unusually high. And so there's something going on here that's causing her eyes to appear wider than usual. So what labs do we want? Well, the first lab I'm going to get in this woman, I suspect thyroid disease, and I'm going to check a TSH, a thyroid stimulating hormone. If that thyroid stimulating hormone is abnormal, which it will be, I'm going to test some other thyroid function tests. So for this lady, the TSH, do you think it will be high or low? Okay, I strongly suspect it will be very low because she's making excess thyroid hormone and suppressing the pituitary release of TSH by the feedback mechanism, the negative feedback mechanism of thyroid hormone on the hypothalamus and on the pituitary. Her thyroid hormones, her T3 and T4 levels, are going to be quite high. We are going to check something else because we know she's hyperthyroid, and because of the eye findings, we suspect she has the condition called Graves' syndrome. So it will be important to check thyroid stimulating immunoglobulin, or TSI. And in this lady, it's very likely that we will find high levels of TSI, thyroid stimulating immunoglobulin. She is making autoantibodies that bind to the TSH receptors on the thyroid gland and then turn them on and keep the thyroid working in spite of a drop in TSH from the negative feedback. How do you think it would be appropriate to treat this lady? I'm going to do some other tests, by the way. She's having heavy periods. It would be a good thing to check a blood count and make sure she's not anemic and do what we can to improve that if we need to. I am certainly going to check blood chemistries, but they're not going to be contributory to the cause of this, which is likely Graves' disease. So how do we treat it? We have to do some things immediately to help her feel better. And one of those things is something called beta blockade. We give her a beta adrenergic blocker, and that's going to mitigate some of the effects of excess thyroid hormone stimulating things like heart rate and triggering sympathetic outflow, and counteract the tremor and the tachycardia and maybe make her feel a little less anxious. We may also give her a medication that blocks thyroid receptors to decrease the effects of the excess thyroid hormone. But we have to do something permanently to decrease the production of thyroid hormone. Back in the old days, that was removal of the thyroid gland, which is a pretty big surgery, and it's not done very often for hyperthyroidism anymore. What is much more likely is that we will give her a iodine radioisotope, and I believe the isotope that's used is I-131. It is given intravenously. It is taken up by the thyroid cells, and generally we eliminate other sources of iodine for a few days before this is given. The uptake of the radioactive isotope into primarily the thyroid gland means that we have high levels of radiation, which basically act as a local form of radiation therapy and kill the thyrocytes and diminish the production of thyroid hormone. There are side effects to this. I once had a patient who, I believe I was a fourth year medical student, and we saw a patient on cardiology. She was admitted to the CCU because she came in through the emergency room and she had congestive heart failure. But her congestive heart failure was a result of thyroid toxicosis, a very high thyroid hormones from Graves' disease. We tuned her up, helped her heart a little bit, got her out of failure, and talked to her about the treatment. And when the endocrinologist told her that she couldn't be around small children or animals for a few days after the treatment because she'd be radioactive, she actually left the hospital against medical advice. And of course, she didn't have prescriptions, and within a week, she was back and even sicker than she was the first time, and ended up finally undergoing thyroid ablation with radioactive iodine and getting completely better. Saw her in clinic several months later as an intern, and she was quite well at that time and had been started on thyroid replacement within the previous week or two.